Hi, I'm Dr. Naaheed Mukadam. I'm an old age psychiatrist and senior research fellow at UCL, and today I'll be talking about the potential for dementia risk reduction and how to make it more equitable. Just some acknowledgements of authors who worked with me on the main paper that I'll be presenting in this talk, and there are also, of course, many other colleagues who've worked with me on other papers, and I'm funded by the Alzheimer's Society Senior Fellowship. So I think in the last few decades, we've had a shift in understanding of dementia away from thinking of it as a largely inevitable consequence of aging and more being able to understand that there are potentially modifiable risk factors that can affect your risk of dementia. And in some countries, particularly higher income countries in Western Europe, for example, there's been a decline in age specific dementia incidence and prevalence over the last few decades. However, most research is based on people of European origin in higher income countries. So, in this talk, I'll be talking about how practical is it to prevent dementia and what would prevention cost. So just to start with population attributable fraction. So this is taken from our Lancet Commission on Dementia Prevention, Intervention and Care from earlier this year. As you can see, there are 12 risk factors that we considered throughout the life course, starting with early life education, where less education is associated with an increase in dementia risk, all the way through to later life, where things such as diabetes, physical inactivity, air pollution can have an impact on dementia risk. And our conclusion was that overall, it looks as though about 40% of dementia cases may be preventable if we target these risk factors. However, what does it mean in real life? Is it possible to implement these interventions in order to actually reduce dementia risk? So the aim for our paper on dementia risk reduction was to find effective interventions to change individual risk factors and to model the costs and benefits of implementing these. And then I'll go on to compare these findings with other countries and also talk about minority ethnic groups in order to see how these findings may apply across different populations. So the first stage was we conducted a systematic review searching PubMed and Web of Science up until March 2020, looking for interventions which successfully targeted any of the pre-specified potentially modifiable risk factors. The interventions had to have robust evidence that the intervention improved risk or risk behavior, and they needed to also be feasible in an adult population. Once we found the interventions, then we conducted a number of calculations. We took a whole societal perspective. So this means we modeled healthcare costs, social care costs, and family or unpaid care costs, and balance these against the cost of the intervention. And so for each intervention, we compared the annual incidence in people with the risk factor and compared the reduction in incidence of dementia if the risk factor is controlled compared with the people who didn't have their risk factor controlled by the intervention, and then compared the annual impact of dementia per person, and then calculated an overall impact in cost per quality adjusted life year. So what did we find? So as a first step, we realized that interventions such as increasing education, for example, were not going to be possible to model in England, which we were using as our site for modeling this work, because in England, education is already compulsory up to age 18, and we did not think that it was practical to get people to attend higher education, even though higher education is associated with a reduction in dementia incidence. And the other factor to consider was how these risk factors targeted risk factors within an individual. So some benefits would undoubtedly be achieved by, for example, reducing air pollution, but we realized that these would have to be implemented at a policy level, so affecting the whole population, and therefore would not be possible to model on an individual basis. So the risk factors with interventions, effective interventions for reducing dementia that we found were hearing aids, antihypertensive, smoking cessation, and diabetes prevention. I'll just go through them in turn. For hearing aids, there's very strong evidence that if someone has hearing loss but they use a hearing aid, they reduce their risk of dementia to the level of someone without hearing loss. So there's very strong evidence that it's protective. And so we modeled provision of hearing aids for anyone who needed it using the standard cutoff for hearing loss based on audiometry tests. For antihypertensives, we again had found very strong evidence in a number of trials that using antihypertensives in people with hypertension reduced risk of dementia compared to people who didn't use them. And this was the case whether or not the blood pressure came below the hypertensive threshold or not. So even if blood pressure remained above the hypertensive threshold, there was still evidence of effectiveness. So we modeled providing 3 antihypertensives as recommended by NICE guidance in cases where people may need more than one medication. So we had a very conservative estimate. And for smoking cessation, again, there's very strong evidence that smoking cessation is effective. And based on a Cochrane review that looked at all different types of smoking cessation, we found that nicotine replacement therapy was generally highly effective. And we modeled provision of nicotine gum to older adults. And finally, diabetes prevention. And the reason we model diabetes prevention and not diabetes treatment is that diabetes, whether treated or untreated, remains a risk for dementia. So we modeled a trial that showed that in people at risk of diabetes, that it was possible to prevent diabetes by conducting lifestyle intervention, which included dietary advice and meeting with a health professional. So what did we find? Well, we found that hearing aids and smoking cessation, although there was a cost associated with providing these interventions, overall, because of the amount of savings that they accrued, these interventions actually saved money overall. For antihypertensives, we found that they were cost effective based on the NICE guidance threshold for cost effectiveness, which is that the cost per QALY was just under £10,000. And as many of you may be aware, the NICE guidance cutoff is £20,000 per QALY. Diabetes prevention, however, was not cost effective. The cost per QALY was very high. So based on the results for dementia alone, implementing diabetes prevention was not worth it. However, for the other 3 interventions, if they were implemented, we found that there would be an 8.5% reduction in dementia prevalence, and overall we could expect England to save £1.9 billion per year in health, social and unpaid care. So that was very promising for England, but how does this apply to other settings? So this was based on our paper from Lancet Global Health last year, where we looked at population attributable fractions for dementia across different countries. And so we looked at China, India, and 6 Latin American countries. And as you can see from the diagram, compared to our Lancet 2017 population attributable fraction of 35%, Latin America, India, and China all had higher population attributable fractions. And much of this may be due to higher frequencies of, for example, low education. And so the implications for this are that in these countries, dementia may be even more preventable. There's more potential for prevention because of the higher frequencies of these risk factors, which, if managed correctly, either through policy or individual intervention, could have a huge impact in dementia prevention. And then finally, just to consider whether these findings apply to everyone in England. So we used relative risks based on meta-analyses that had previously been conducted for each of these risk factors. And most of the studies that were used to calculate those relative risks have been in cohort studies that have primarily white participants, often in higher income countries. But we don't know that the relative risk is the same for everyone. And certainly from, for example, the SABRE study, which is referenced on the slide, there were findings that in cardiovascular disease, for example, each risk factor, such as hypertension or diabetes, increased the risk of cardiovascular disease and stroke more in South Asian participants and in the Black population compared to the white British population. And there's from those studies, there's some suggestion that this may be because of arterial stiffness, so different ways in which the body responds to cardiovascular risk factors. But so just to expand on this finding, we've been looking at risk factors in South Asian and Black participants in the UK and their impact on dementia. And our preliminary findings are that these risk factors increase the risk of dementia more in minority ethnic groups compared to the white British population. So again, this indicates that there may be the potential to do even more in terms of dementia risk reduction in minority ethnic groups within the UK compared to the white British population. So this just highlights that not only do we have to take the country into consideration and the pattern and frequency of risk factors, but we also need to think about for each individual, what risk factors do they have, but also what impact do those risk factors have on their dementia risk, because it may be different for people from different ethnicities or different backgrounds. So this highlights the importance of really tailoring dementia prevention for different populations and for different groups of people within each population as well. Just to summarize, our main findings were that dementia is potentially preventable based on all of these risk factors, but that not only that, but that prevention is likely to be cost effective and even in some cases cost saving. And of course, as I've already said, it's very important to look at each country or region and see which risk factors are the most important in terms of their population attributable fraction. And then within those countries, focus on tailoring to different ethnic groups because they may have very different risk profiles. So thank you very much for listening, and I look forward to hearing your questions later.